Hello everyone, welcome back for those that you were here with us this morning, and welcome to everyone that's joined us for this session. This is the part of the Psychosocial All-Day Seminar, and this is our second session, and we're very proud to introduce you to Marney Thompson. So what we'll do is Marney will present, and then we'll have time for questions and questions and discussions. So keep your questions, and we'll be very happy to organize that at the end of the session. Just a little bit about Marney, and I feel that I can call her Marney because we've known each other for quite a number of years, and I'm privileged to have and know Marney for that long. Marney is a registered clinical counselor. She's currently the Director of Bereavement Services at Victoria Hospice in BC, in British Columbia, Canada. Since 1994, she worked in inpatient and community palliative care settings, providing information, support, and counseling to patients and their families. Marney is co-author of the book Transitions in Dying and Bereavement, a psychosocial guide for hospice and palliative care, which won third place in the American Journal of Nursing's Book of the Year Award in the palliative care and hospice care category. She recently co-authored an article published in Death Studies titled Experience of Grief, Bereavement After a Medically Assisted Death in Canada, Bringing Death to Life. She has been working as a counselor at the Canadian Hospice Palliative Care Program for more than 20 years and loves what she does. With wisdom, humility, and deep respect, she has counseled people of all ages from all walks of life as they encounter the difficult transitions and transformations that often accompany serious illness, death, and bereavement. She completed extensive supervised training in prolonged grief disorder treatment through the Center for Prolonged Grief at Columbia University. She also has experience working with people who are bereaved following sudden losses such as illness, accident, suicide, and overdose, and also those who are bereaved following a sudden or prolonged illness. She is honored to support people living with loss and continues learning from this unique and rare privilege for many years. I welcome to the podium Marney Thompson.
Those bios always seem so much more impressive than you feel when you're standing up in front of here. I just want to kind of out myself as a very nervous, introverted presenter, but if you trust me and come along with me, I do settle down as we go. I just wanted to begin my presentation to say how over the moon excited I am to see a psychosocial stream at this conference. I have been working in palliative care for 30 years as a counselor, and coming to this conference and trying to kind of weed through lots of other content to find the psychosocial stuff. And I'm just thrilled and so appreciative, especially to Zeldra and Patrick, for the work that they've done to make this happen. So yay for us. I think that it's important that psychosocial people come together. For those of us who heard Terry's talk already this morning, this will be a bit redundant, but we're often one of and kind of rare in our programs and teams, and I think the opportunity to spend time together, to see each other, to support each other, and to speak to each other is so important. And I wanted to begin today with a quote from an article on the strengths-based perspective in social work practice by Dennis Salibi, and the quote is, "Social workers need to ensure that the diagnosis does not become a cornerstone of identity. Whatever else symptoms are, they may also be a sign of the soul's struggle to be alive, responsible, and involved. Care of the soul is a continuous process that concerns itself not so much with fixing a central flaw as with attending to the small details of everyday life." And that was so present for me, and I don't know for others in Terry's talk today, those small details. So thank you all for being here, and I will get started. Oh, learning to click there. I have no conflicts of interest to declare, although I will say that the content I'm using today comes out of a book that a number of us at Victoria Hospice wrote about psychosocial transitions in end-of-life care. I don't benefit at all personally from sales of this book. My learning objectives in the presentation today are to introduce all of you all to the idea of psychosocial transitions as they relate to the palliative performance scale and the disease process, to help you to consider key considerations for select psychosocial transitions, and to invite you and challenge you to apply this information to the work that you're doing with patients and families in your settings. At the root, what I really hope to do is provide you with a good tool, some form of a roadmap that you might use to more intentionally bring the psychosocial aspects of illness, death, and grief into your practice in palliative care. Oh, I have to press hard on this button. There. I think it's important before I speak about what I've learned and what we teach and do to orient myself in the program that I come from. I have had the privilege of working for the last 30 years at Victoria Hospice, which I would say is a mid-sized community hospice program in Victoria, BC. We have a comprehensive program of care that supports people facing illness, dying and death, and bereavement in their homes, in the community, and within our inpatient unit. We are an interdisciplinary team of nurses, physicians, counselors, volunteers, spiritual health people, and many others committed to excellence in end-of-life care. Our mission at Victoria Hospice is to enhance quality of life through patient and family-centered care, most importantly, but also education, research, and advocacy. And I wanted to create that context because, again, I feel like it's important to acknowledge that I come from a program with a broad scope of services, with a large interdisciplinary team, and with a scope that includes more than direct clinical care. Research and education and advocacy have always been part of our focus. And I know that that's not the same for many psychosocial people, that you might be one on a team and not have that sort of broad team around you or those other opportunities. Because I'm talking about the psychosocial PPS, I think it's important to just spend a moment wrapping our heads around the PPS, which is the Palliative Performance Scale. This is a rather complex tool and a dense slide, but I'm going to take a moment with you to talk about it in more detail. So the PPS, as we call it, was developed by a team at Victoria Hospice as a communication tool to be used between interdisciplinary palliative care team members and individuals. Our hope with it, its initial function, was to support us in analysis of the nursing workload for home care nurses, to also help us to profile admissions and discharges from our inpatient unit, and also with prognostication. So just take a moment and have a look at this slide. It's fairly dense. I'm going to talk a little bit more in detail about it. The way that this scale works is that PPS scores, so whether a person would be said to be at 100% or 20%, is determined by reading horizontally at each level to find the best fit for the patient that you're thinking of, who is then assigned a PPS score. And I think it's important when you're looking at this tool to know that the leftward columns, so beginning with ambulation, hold more strength or are considered to be stronger determinants of someone's PPS score than as you move across to the right. So those leftward columns take more precedence over the ones to the right. So just taking a moment then to go over this PPS scale a little more, that first column, ambulation, you see when a person has a PPS of 100%, they're well. They're fully ambulating, there's very little evidence of disease. And then as a person moves along in the PPS, they go from full mobility and activity to reduced, and then down towards 40% where a person is mostly in bed, to 20 and 10% where a person would be totally in bed, and then the time of death at 0. The next column relates to activity and evidence of disease. So how much is this person able to do and how present is their disease in their day-to-day life? And again, no surprise at 100%, they're doing their normal activities of life, working and hobbies and interests and chores, and there is no evidence of disease. To them, when you get more towards the 70 and 60, where a person's activity is with effort or reduced, to the point where at 40% they're unable to do most of their activities and there would be extensive evidence of disease, to 10% where they're not really doing much at all, and again, extensive disease. In the middle column around self-care, what we're talking about is the person's ability to take care of themselves. So at the higher PPSs, they're fully managing all of those things on their own. And then towards the middle at 60 and 50%, occasional to considerable assistance needed with those personal care activities. At 40%, it's mostly with the help of somebody else. And then from 30% on, often total care. The fourth column around intake has to do with people eating and drinking. And I would say for patients and especially for family members, this is a really important and difficult change as the disease process progresses. So at the beginning, normal intake and appetite, and then as we go down the PPS, it becomes more and more reduced to at 20%, a person might only be taking sips, and then at 10%, mouth care only. And then the last column, I think, is often the most distressing for family members when present. This has to do with consciousness. So is the person awake and aware? Are they able to interact and communicate? Are they experiencing periods of confusion or disorientation, drowsiness? So again, early on in the PPS, full consciousness level. And then towards the middle, confusion may become present. At 40%, a patient may become more drowsy. They're sleeping more. It's harder to stay awake for long periods. And then towards 10%, they're drowsy, often sleeping most of the time. Some people would describe the person as being in a coma, and they may or may not be confused. Anyone have any questions about the PPS? I'm not a doc, but I would do my best to answer if you have any questions there. Okay. Oh, I went too many now. Oh, no, I didn't. So, as I was saying, I'm fortunate to be in a broad team with a lot of professionals and a big scope. I also have been very fortunate to be mentored by someone who I think is one of the champions in psychosocial palliative care in Canada, Wendy Wainwright. She's now retired, was a fierce advocate for psychosocial care and the role and value of counselors and social workers in end-of-life care. And with that lens that she has always held so fiercely, we were curious about how we might use this PPS tool in our program. So as educators, we were looking for new ways to bring a whole person, strength-based, holistic lens to care in a more intentional way. We wanted it to be obvious. We invited ourselves to wonder what else is important for us to know about this person and family and their concerns and needs and wishes. And importantly, looking at the slide, how can we use this widely used communication tool, the PPS in our program, that is patient-centric and physically focused to introduce a more holistic patient and family-centered approach to care? We wanted a way to create dialogue with our teams in a way that was familiar and recognizable to them, that began to insert psychosocial concerns and issues into the way that we looked at patients and families. I'm going to spend a bunch of time on this page here. So the way that we did that is we looked at the information we had, which were referrals for and requests for counseling service within our program. We tracked over a year of referrals that came from the community, and we had a number of questions that we wanted to know as we were looking at them. Who was the referral for? Was it for the patient or for family members? What was the stated need or identified need on the referral form? What were we being told was needed? what was the PPS score at the time that the referral was submitted? And then interestingly, what did the counselors do once we got out there? And we looked for that in their charting and their notes. And then also importantly, where did the referral come from? Because we wanted to know if we began to understand what's going on at different PPS transitions for people, who else needed to know about that? Where might we use this as an opportunity to provide some training and education? And as we looked at all of that data, we saw that, in fact, there were transition points along the disease trajectory and that they related to the PPS. And so we wrote a book about it twice. We first wrote the transitions book in 2003. At that time, there was hardly any psychosocial research and content for us to pull on, and so we leaned very largely on the data that we had and the anecdotal experience of our team. And then we were asked by the publishers in 2016 to make a revised edition, and so we republished and revised the book in 2017. And thankfully, and for me as a long-timer, as a psychosocial person in palliative care, by then there was lots of research and data that we could pull on. And so I think both Wendy and I were really excited to be able to rewrite the book and really inform it with a lot more research and evidence out there. I want to say that although the book that we've written covers from the time of 100% PPS all the way through to bereavement, in my presentation today, I'm only going to be covering a select few of those PPS transitions. It's just too much content to do in the hour that I have, and I've tried to focus on things where I think the most of us would be interested. So I'm going to cover today the transitions from 60 to 50% PPS, and then from 40 to 30% PPS, 20 to 10, the time of death, and then into bereavement. And before I go into talking about the PPS, especially in light of Terry's presentation this morning, I just really want to emphasize that it's important as we look at the PPS and the psychosocial transitions that we've identified, that we all understand this is a guide, not a prescription, and that therapeutic alliance is what's most important when we work with people in all realms, but especially psychosocially. And so safety and rapport and what the patient or family, what people are telling us they need, supersede these categories and key considerations that we've come up with. This really, again, as I said at the beginning, is meant to be a roadmap and an invitation to stop and consider what might be unique to this time in a patient and family's experience of illness. So, the first transition. This is the PPS transition from 60% to 50%. And in our book, we call this the shift to hospice palliative care. Although, and I think it's good news, there's been much more upstreaming of palliative care and the palliative approach in our country and I think around the world. This often is a time where the really intensive specialty focus can shift for people and they get introduced to palliative care supports. At this time, the patient typically isn't getting out of the house much and won't be able to manage a full load of work or household duties. Their family and friends may have or be thinking about adjusting their schedules to help with the needs of the person who's ill. And everyone may be grappling with uncertainty about what to expect and struggling with what to talk about, what to say, and how to talk about it. It often for people is a time of fearing the worst while also hoping for the best. It's a very mixed time where you're moving often from one system of care to another, one team to another, and feeling a kind of pressure to reorient to what's happening. So as I talk about these PPS transitions each time, I'm going to go across about the patient first and then through for family members. So in this transition, looking at that patient line horizontally, the first key consideration that we've identified is a change in focus. So often for patients, there's a shift in focusing on managing the disease, going to tests, going to appointments and treatments and hearing perspectives, to managing one's life. There's sort of a so what next. There often can be less busyness in terms of interventions and testing at this time. A next consideration is losses for the patient and family. It's a time where, as the disease presents itself more fully for the patient, they may be getting out of the house more and are not interacting so much with the outside world, and so there's a sense that life is getting smaller. It's a time of ambivalent emotions, that third consideration around emotions, where people are balancing both hope and denial. There's a hope for more time, there's a hope for a miracle, there's a kind of protective, I think, reflex not to think about the possible end of life or death to come. There can be real fears about the future, like what's around the corner, what else am I going to experience as my symptoms change or increase? Am I going to be getting into pain? Will I be able to handle it? Will there be people there to help me? And around communication, that it's a time where people are really tentative about what to say and how to talk about what's going on. So patients in particular not wanting to scare family members, not wanting to upset them, but also having lots on their mind and in their hearts. It can be a time where it's hard to find the words, as I said earlier, where there's a lot to say, but people are juggling with how to talk about it. For family members, that key consideration around change of focus, sometimes at this time when people are shifting from one system of care to another, one team to another, there can be a feeling of abandonment for the patient certainly, but also for family members who've really relied on those caregivers for information and ideas and direction. There's a new system oftentimes to learn when a person shifts to a hospice or palliative care program. Around losses, family members too, like the patients, are dealing with a change in focus, a change in caregivers and familiarity. There can be changes and resentments around loss of freedom and ability to manage the other things in life that can happen for family members. Around emotions, family members at this time often experience a real, and this can be true all across the PPS trajectory, but in particular at this time, feelings of powerlessness around not being able to do anything to prevent this, not being able to stop the change, not be able to make it better. And also fears about both what's to come, what their person is going to go through, but also if they'll be able to manage. And at this time, those communication differences really magnify, where you'll have some people in the family who are ready and willing and want to speak directly about what's going on and make plans and be concrete, and others who prefer to keep that reality out there and not talk about it directly. The next PPS transition we've called illness predominates. So at that time where a person is shifting from 40 to 30% PPS, thinking back to the PPS chart, you know, they're often more sleepy. They're probably not getting out of the house much at all. Their ability to visit and engage is more limited. So at this time, the person who's ill is mostly in bed and likely not doing a whole lot. Their symptoms may be increased and they could be resting or sleeping most or much of the time. Although they may not be eating a whole lot, their care needs will increase. You think of a person at 40 and 30%, they're needing help with personal care. They might need help with feeding, they might need help with bathing and toileting. So it's a time where illness predominates for both the patient and family. And at this time, family and friends who are caregivers, who are providing care for the person who's ill, may become more isolated as the patient is less engaging, they're tired and they're sleeping more, but also that family member is more tied to the home and being close with the person who's ill, and so they're not getting out for those activities and hobbies and social relationships that help to fill their lives. Socializing is much more difficult at this time. So then again, going across more intentionally for patients at this PPS transition, a real change in mobility. They're probably not getting up and around easily or often or far. So again, that adds to that shrinking world experience. Their symptoms are often increasing. They could be new symptoms coming on or symptoms increasing. So thinking of pain and dyspnea, confusion, loss of appetite, nausea, all of those things could be coming and again impacting that person's ability to get out and move around. There can be one of the key considerations is dependence and withdrawal, and I think that real tension for the patient themselves around knowing that they're needing more help and not wanting to be a burden on family members. Along with that, sometimes a loss of control, feeling like I don't want to have to depend on other people to take care of myself, and I feel like this disease is just doing what it wants with me and I don't have a lot of control. Grief within the family, and for the patient, often the patient feeling tired and low, and maybe feeling some feelings of guilt around the sadness that they're bringing on the family, the work that they're bringing on the family, and feeling guilty and badly about that. Again, relates to being a burden. And stress and fatigue. For the patient at this time, they may be much more, I remember when I was working more directly before death with people, I would talk about patients having teaspoons full of energy and really being very intentional about how they spent it and with who. And so having to be strategic around, you know, when that important family member or friend is coming to visit, when's the best time of day when I've got the most energy for it? And the stress of that, you know, wanting to be there and wanting to be able to engage with people, but also just not having a whole lot of energy. For family members at this time, that change in mobility can add increased physical and personal care needs, so they're more involved with the patient and again, more tied to home, as I was saying. They may be taking on more of a decision-making role around what to do, when people come. You know, there's kind of I think a social gatekeeper function that happens for family members around this time. Again, wanting to acknowledge and protect the amount of energy that the person has. Also for family members, that the reality or the anticipation of the death becomes more present as they're seeing more symptoms in their person, as their person is less able to engage with them. They're beginning to kind of get little hints and hits of anticipatory grief. And again, I do believe that grief begins sometimes at the moment we get a palliative diagnosis or at the moment we even get an illness. But for family members, it's much more present now when they're in the hands-on caregiving. They're seeing those physical changes in their person's body and beginning to anticipate death much more directly. And around stress and fatigue, as I mentioned earlier, real isolation for family members. And there may be stresses within family members when one person is assuming or taking on the leadership around caregiving and not leaving space for others, or there can be resentments within family members when people aren't being invited in to help with care or aren't showing up. The next transition that I'm talking about is as death approaches. It's that change from 20 to 10% PPS. By this time, patients are totally bedbound. They're not engaging very much with others and sleeping most of the time. They are often only awake for brief moments, and in those brief moments, they may be fully conscious and oriented, but they could also be drowsy and sleepy, and even disoriented and confused or restless. Family members at this time often feel very reluctant to leave the bedside, anticipating that death is near and feeling conflicted about it. On the one hand, recognizing that with death, there may be an end to the struggle and suffering of their person that they've been watching through this process, but also some deep and real sadness about not wanting their person to be gone. So going across for patients at this time, there often is very little or no kind of visible interaction with others. So they're not sitting up in bed holding conversations, they're not playing cards, they're not having often big, long conversations about the meaning of life. These are brief and very subtle and intimate moments with family. Could be cuddles in bed, it could be hand-holding, brushing hair, stroking, bathing, those kinds of things, but not interaction as we, when we're well, expect it to be. The patient at this time may also be speaking symbolically. They may talk about traveling or going home or maybe speaking about or seeing family members who've died. It's a time where the wishes of the person who's dying may or may not be known. And so that's a really difficult place for family members if they're not clear and they don't know what their person would want. Is home the place to die, or is hospital the place to die? Is a hospice unit acceptable or not? Should people be present or not present? This is a time where these considerations in particular weigh really heavily on family members. There can be expectations of death coming to bear. So is this a person coming to the end of their life who had a lot of fear about how dying would go? Is this a person, thinking of Terry's talk earlier, who has some family legacy stories about death being awful or wonderful or what? So how that person who's coming to end of life has oriented to the end of their death would be present at this time. And knowing that, knowing how the patient felt about it would be influencing how the family make decisions. And restlessness and confusion could vary. It could be not present at all, or it could be very severe. And this symptom, I think, is one of the most difficult ones for family members to grapple with, particularly when they're at home on their own caregiving. For family members at this time, connection often involves sitting vigil. As I said earlier, it might be hand-holding, it might be snuggling in bed beside the person. Family members are often troubled and frustrated at this time with communication, like how do I get my message across to this person? How do I be sure that they know I'm here, that they know that I love them, when there isn't that kind of direct feedback where the patient isn't able to respond back? As I said earlier, family members at this time may be making decisions on their own, and that could be informed by what they understand the patient's wishes to be, or it may be just their best guess. And sometimes this is a point of tension within families where one person thinks, no, Dad absolutely would not want to go to hospital, he wants to be here, and another family member is feeling like, yeah, but if he knew it was going to be like this, he definitely would rather be in hospital. So that decision-making process is escalated and heightened for family members at this time. And again, expectations of death. So families beginning to think about, what is the death going to be like? Is this the day that my person's going to die? Will I know what to do? Is there something I should be doing? And again, a real mixture of relief and sadness, sometimes anger. You know, sometimes this is the time where families are feeling like, if only I'd insisted, or if only my person was a better patient, had gone to the doctor sooner. It can be a time where those kind of doorknob feelings begin to surface. Around restlessness and confusion, there may be concerns and questions for family members about what they're seeing and hearing. If the person is very quiet and unresponsive, there can be concerns and questions from family members about that. Like, is my person too sedated? Is he too doped up? Does he know what I'm saying? Is he able to hear me? If there's confusion present, it can be difficult for family members to know how to respond to it. Do I reorient my person when he's talking about going home? Do I say, no, Mom, you're here. You don't need to go anywhere, you're here. And so trying to deal with that symbolic communication and some of that confusion that can come for people. Also, pre-death restlessness is a very difficult symptom, again, that can show up anywhere along the illness trajectory, but particularly at this time, I think can be really difficult for people to know kind of how to manage that and find access to care teams who can help. And then the last transition that I'm talking about here is time of death. So the patient has died. And even though the death was expected, it often can feel like a surprise for people. It may have been sudden or slow. It might have been peaceful or effortful. But no matter how we perceive it to have been, it's really important that we give people space to talk about how it was for them. Not to be too quick to reassure with, he was at peace, it was okay, there was no pain, but really give family members and caregivers a chance to speak to what they saw and what they heard. Many people will have never been with a person who died before and not know what's okay to do or not do, not know how to interpret the things that they saw or heard or even smelled. So I think it's important to really take time here, and I think Terry touched on this as well in her presentation earlier. This time of death is a really important transition that I see now, working the last 10 years exclusively in bereavement, is so pivotal in terms of how people come into their bereavement experience. If there are kind of unanswered, and my old boss would say, pointy questions around how the death happened, that really colors people's bereavement experience. So I think it's important for us to model what's appropriate and what's normal, and to provide invitations to let people know, if we can, that they don't need to rush, that they can spend time with their person who's died, that it's okay to touch them, that it's okay to lay with them if they choose, and to really kind of find out from family members what's important and what needs to happen for them. So going across here around key considerations at this transition, as I spoke to earlier, the nature of the death, that people may have questions or concerns, even if it was expected, even if it was peaceful. So really to take some time with people to talk about how it went. If they were there, they may have questions about what they saw and heard. If they weren't there, they may need to know how it happened. They may want to know, was anyone there, and what might my person have been through? The reactions can vary at the time of death, from kind of autopilot and zombie or numb and shocky to intensely emotional and overwhelmed. People can be sitting beside their person who died and still feel disbelief about it. People also, again, might feel a sense of relief and have some feelings of guilt about that. So I think, again, really important when we're there with people to normalize that wide spectrum of response, and to know that we all come at this with different life experiences behind us and different ways of coping, and that getting really busy and doing things is just as to be expected as on the floor and sobbing. Some family members may be focused on the practical details at the time of death. So I think as professionals, it's important for us at this time to talk about the care and removal of the body. As I was saying, are there things that the family members or caregivers want to do? To spend time, to touch, to talk to their person, but also I think important for us to introduce them to what happens next. So if death happens in a facility, who gets called? Does the funeral home come? What does that look like? What to expect? If death is at home, again, what is the related procedure? That time of the break between the family and the person who died is often really impactful. And so I think the more we can do to let people know what to expect and to hear some of their concerns and questions and address those, really the better for them in the moment, but also down the road. And the last, to explore with people whether there are any special rituals that they have that they want to do with the person before they either leave the facility or the hospital unit or their home. People may have rituals and beliefs and they may not, but I think it's important to ask. And then I'm going ahead now into bereavement. As a longtime grief counselor and grief educator, I feel like it's really important at the beginning of these to really underscore that I am not talking about stages and phases of grief. I think probably most of this audience knows that people can experience all things and some things, and that it's different from person to person, but I am trying to introduce again a bit of a roadmap for us to have a place to begin from when we're supporting people in their bereavement. So this first part after the death we're calling walking the edges. In the early days and weeks of bereavement, people tend to oscillate. There are times of searing grief, which might include sadness, anger, guilt, fear, loneliness, that are interspersed with time in shock and disbelief. And people often kind of move in and out of that. And I think it's very self-protective and normal and natural and good, really. At this time, people get it intellectually. They know that their person has died, but it still doesn't feel real or true yet. There's still a piece of impossibility about it. Like, I can't believe my mom's not going to be calling me at the end of the day today. For many bereaved people, this is a very busy time with lots of practical and financial decisions to be made regarding things like a death announcement and funeral or memorial plans, and any immediate kind of financial and estate concerns that need to be addressed. And unfortunately, and I'll explain my unfortunately in a moment, unfortunately, this also tends to be the time when the most support people show up. So you can imagine a newly bereaved person kind of in shock and autopilot, got lots of details to take care of. There's a lot happening within the family. And this is when the neighbors and the friends and the extended family are making the phone calls and showing up on the doorstep for hugs and bringing food. And again, that basic survival support is so important, but it also, I think, often gives those support people the impression like, wow, this person's actually doing all right. You know, she was up, she was dressed, she was making phone calls, she was heading off to this, she was buying food because the family's coming into town. And I think it gives a bit of a false impression that people are doing okay in that very kind of early time of grief, when many of us know there's still lots more to come. So around walking the edges and the considerations of this time, grief reactions, again, there's a wide range from autopilot and busy to emotional and overwhelmed or incapacitated. That there's a lot of stuff going on around family interactions and family dynamics where roles are changing. It may have been that the person who died was normally the family organizer or communicator, and now somebody else needs to take on those roles. There can be feelings of confusion and hurt, and confusion around, how come my mom's doing so well when my dad died 2 days ago and I'm not? Or hurt around people kind of judging other people's ways of coping. So it can be a really fraught and intense time in families. It's also a time of coming together. One of the key considerations is around support, and I spoke to this earlier. It's typically when it's most abundant, when the most people are around, mowing the lawn and bringing food. And that support could be welcome or intrusive. The family members who are kind of most immediately impacted by the death may be on a mission to take care of details, and all these visitors at the door can get overwhelming and frustrating. It may be a time where well-meaning people have made remarks that kind of fell flat or were tone deaf around, he's in a better place and at least you have X. So it can be a really difficult time around social supports and connections. And it's also, as I was saying, a time with lots of practical details to take care of. The next point along the way in people's bereavement we've called entering the depths. And as time moves forward, the bereaved person's life begins to slow. They're less busy with all those details, and the full reality of the death is settling in. At this time, people often feel worse and are puzzled by it. They're concerned that their grief over time isn't getting better and may in fact be feeling harder. They may be experiencing intense and prolonged sadness, loneliness, and even despair. As the kind of full weight of this loss comes to bear on them, they're waking up in the morning not surprised anymore that their person is gone. They're waking up knowing that they're gone, and that brings with it a different kind of heaviness as the shock and numbness have worn off. And as I was saying earlier in that previous transition, also their supports may have begun to recede, leaving the bereaved more alone at this time when the full weight of the loss has come to bear. In my program, and I'm working now exclusively with the bereavement team in the bereavement program, this is typically where people come to us looking for support. This is where people often first enter our program, looking for information about grief, what's normal, what to expect, am I doing this right? Looking for companioning and support with other bereaved people or our volunteer supports, and also counseling. The next piece here we're calling reconnecting with the world. By this time, the intense lows and highs of grief have often subsided for the most part, and people will have more energy available for the ongoingness of life. They may be exploring new activities in their personal life or at work, and building relationships, making new friends, or reconnecting with old ones. It's a time where a lot of that energy that at first went to all the details after the death and then was consumed with the kind of emotional and cognitive process of taking in what this means and how it impacts me, that energy is now more available for other things, and people are reinvesting in their lives in a way. There is often by this time an internalized sense that the person who died is still with them, either in spirit or memory, and there may also be things that the bereaved person is doing to reinforce that connection. So it's a time, I think, when someone first dies, we feel like we've lost that person out there and we want them back out there. We want to see them and feel them and touch them and hold them. And over time in grief, we begin to have kind of a more internalized sense of them, where there's a way within us in which we can connect that's still there. I remember when I was doing my prolonged grief disorder treatment at Columbia with Catherine Shear, she talked about how over time in grief, there's a way in which we kind of can recall people and hold people in our mind's eye like we do when they're alive. Every day we're having experiences that we might want to share with someone important in our lives and they're not there. And there's this sort of like, my daughter would love this. She would think this is hilarious and she's not here. And so there's a way in which we kind of connect with that even before they're gone. And that begins to come, I would say kind of becomes renewed again over time in grief. At first, we're really very focused on, I want the person in the flesh. And as time goes on in grief, we begin to discover ways that they're with us still. And around activities that we do, there may be ways in which we kind of maintain a legacy or an honoring of the person that we've lost through our activities. So it may be if there was an interest that you shared with the person who died, that at this point you're able to kind of return to it and do it with the full pleasure of what it was, but also a sense of like, this is something that mattered to my person as well. It could be a time where people are hosting fundraising runs for a cause that mattered to their person, those kinds of things. It's also a time where there's an understanding, and I think this is really important for people who are bereaved, but also for us as professionals to know that grief, just like love, is everlasting. I think people at this time have kind of come to a place where they're beginning to reconcile that there are always going to be pangs, there are always going to be twinges where a song comes on or a scene is in front of us and we really miss our person who's died. And we kind of are able to kind of acknowledge that and hold that in a way that doesn't undo us in the way that it did in our early days. So around the considerations for reconnecting with the world at this time, we've called one emerging. So people, as I've said, have more energy available for their lives. They're more able, I think, both kind of in spirit, but also cognitively, their brains are more available for new and novel learning. They're ready to take on new tasks. They're ready to pursue new interests. There's an understanding that grief is ongoing, that grief is forever, and it moves in and out in waves or pangs, and it brings with us a kind of bittersweet remembering of our person. And also more focus on identity, a sense of who am I now without this person? What does my life look like without the person who's died? So I wonder, well, Patrick or Zelda, can you give me a time check? How many minutes in are we? 10, okay. So I wanted to really invite all of you to take a moment, because I've been going to conferences for 30 years and I take in all this exciting stuff and I'm all full of it and it's just gone by the time I get back to my hospice. So I just want to invite you to take a moment with a partner beside you, if you can, to talk about what out of this stuck with you. You know, what are some points that I may have talked about that resonate or even rub with you? What stuck with you? What is something that you've learned here in this presentation that you could take back to your work and do differently in your setting, in your care of patients and families? And who else might benefit? Is there somebody else that you would like people on your team to, are there other people on your team that you would like to have this information? So we'll just take 5 minutes, and then I'll use the last 5 minutes or so to answer any questions that you guys have. Thank you so much for your attention. So just take 5. I've got a dinner at 8 o'clock at It's gotten quieter. Oh, you want to? Okay, everybody, is that enough time, or do you want a few minutes more? I love it when you get busy talking. That's great. That's the magic. Okay, if I could have everybody back focusing on the front, not on me necessarily, but kind of coming back to the larger group. You'll see on my last slide here, I really just put that up to give people some contact information in case people wanted to reach out to me later and ask questions or ask for materials. I'm happy to share my slides if they're useful to anybody. So know that. And I just wanted to ask, what kind of things did you get to talking about? What stood out for you in this presentation that was awesome or a rub? What was the discussion like? Can anybody share?
Patrick has the mic.
Hi, I'm
Hi.
Nicola from McGill, recent graduate of a fellowship in palliative care. Not actually working in palliative care, but nice to be back here for the weekend and for the week. I happen to be sitting next to someone who I trained with in my fellowship, Dr. Cheng. We were talking about how it does feel like in certain settings where we work and worked that the accompanying a patient's family through the dying process is really like the tip of an iceberg. And it was really kind of like a wake up to hear some of the things that we're involved in, how they can have lasting effects in the bereavement process that can go on for much longer than the time that we even have with the patient and the family members. Mm-hmm. It's more of just a comment that was a big takeaway.
Awesome.
Really kind of tried to brainstorm a bit how that follow-up goes, and there isn't that much actually in the wake of COVID in terms of follow-up for the patients and the families, the families that come through the hospitals. So, and also I'm going to buy your book. It's great.
Great. Yeah, it's a very good point. Many of our programs aren't really designed to kind of hold on to people, family members after the death. It's interesting. I got to be part of a team doing some research on assisted death, and it was physicians, nursing, nurse profs, like kind of a bunch of us and counselors. And one of the things that was a kind of light bulb for me was that one of the docs on the team saying, my relationship is with the patient. It's not with the family members. And so I have a kind of professional obligation to take care of the patient, but not the family, and that's more of a moral obligation. And in that realm of moral obligation, it's really variable in terms of what people feel like they can take on. And it's a little bit like that with dying generally, I think, in our healthcare system, where we've got a lot of resource and attention to people in that before death part, but not really thinking of the health outcomes for family members if death is confusing or unclear or doesn't go well for family members down the road.
Do you know of any more widely available resources besides those local ones that are connected to our individual institutions for grief counseling or support, for example, in Canada?
Yeah, in Canada, and I think it gets used internationally, but in Canada, I think an excellent go-to resource is mygrief.ca by Canadian Virtual Hospice. It's been through a really big revision lately. I've been fortunate to be part of the rewrites of lots of stuff. So there's grief information there for the general public. So someone who's bereaved can go there and in a way find themselves, like I'm grieving a death from a suicide, or I'm a partner of someone who died. there's kind of much more category and nuance than there used to be there. But there's also a ton of good grief content for different settings and professionals. So stuff for paramedics, stuff for ICU docs, stuff for long-term care setting. So I think that's a great resource. And also the other thing to say about, well, I guess it's not mygrief.ca, but Canadian Virtual Hospice has an Ask a Professional function on it, where anyone, professionals or the general public, can type in a question and get an emailed back response from a team of professionals that work for Canadian Virtual Hospice. So I know in the past, Maxine Ratner and I are both part of the psychosocial response on Ask a Professional, but there are also nurses and docs and chaplains as well. So that's a really good resource for people. Any other rubs or useful bits that came out of this presentation for people to share? Yeah, and there's two over here, I think.
Thank you very much for a great presentation. My name's Brendan. I'm from Australia.
Hello.
And I loved the opening questions that you gave as a way into that conversation to open up that space with a person and their family. And I also thought that it would be really easily adapted for me in terms of maybe an in-service with the nurses that I work with, and thinking about those particular referral points and what we might be looking for in referrals at those different stages. So thank you very much.
Awesome. You know, it's funny, I meant to speak to the opening questions and the interventions in my slides, and it went away in my anxiety and nervousness, I think. But I'm glad that you noticed them, and they're really just meant to be kind of a general orientation. You're going to put them and translate them into your own words and something that fits the person in front of you. But they are kind of, I think, really good baselines to have in mind when you sit down in front of a patient or a family member. So thanks, I'm glad you noticed.
I feel like we were eavesdropping. But because I would say exactly the same thing. But one of the things that we talked about in those questions is that sometimes you just say to people, do you have any questions? Well, people don't really have questions, and so it's not a good word. It's always about the actual words, right? And that's why your directions at the bottom were so wonderful, to really give some ideas about different ways to say things. What did we think we would say?
I do a lot of bereavement phone calls for families after somebody dies in hospital, and I ask that question, do you have any questions?
Right.
And I realize now I think it's too vague, and people are so overwhelmed and shocked, and to just be a little bit more direct or specific about, you know, do you have questions about what happened when your loved one died? Even just to give them that permission to be able to talk about it, or to realize that's normal and it's okay.
Awesome.
For me, I love the structure. I have to have models to follow. That's the way I think. And for teaching young physicians and nurses and social workers, you know, to use that in the ICU when people are coming near the time that they have to make decisions and get closer to the time of death. It's a wonderful teaching method, so thank you.
Awesome. Oh, I'm so glad. Great. It's one of the things and I am absolutely not here to pitch the book, but it's one of the things we wrestled with, particularly Wendy and I, in the writing of the book, was whether to put scripted questions in there. Because, you know, the way I might say it could be completely different than how you would say it, and also very different than the moment with that person. But I think it just begins to kind of give you a bit of an orientation to find your own words for things. And that's all the way through the book. Each transition each consideration has questions that go along with them, and a number of them. So I'm glad you found that helpful. It's good.
Question online about how to access your book.
I had made little postcards about the book so that you can know how to find them and how to get them. So those are here if anybody wants them. I did put some at the back. But also it's on Amazon, and you can order them through the Victoria Hospice website. We have our own website. We make a little bit more money, I think, if it comes through our website than Amazon, but do whatever's convenient for you. And make sure you get the most current one, not the older version.
We're going to open up the room to questions now, and we'll do one question from online, virtual. The question is, I love the way this is formatted and would like to use it for education with medical residents who rotate through our palliative care clinic, as they are very familiar with the PPS. What is the best way to access them? To access the format, I guess.
Well, it is all in the book, so the book is certainly one way. We've had a few-year hiatus, partly COVID-induced, but Victoria Hospice has also runs a psychosocial care of the dying and bereaved course that this is a big part of the backbone of. So if and when it gets up and running, that would be a good way to get the content. And also I'm happy, as I said, to share my slides with anybody. So if people wanted to email me, I would be happy to give them what's there. The last two, just in case anybody, if this is useful, the last 2 pages of my presentation are the handout. So if that's useful to you to have to take back to your settings, ask me to email it to you, and then you've got those to be able to use. That may also work for those people.
Oh, there we are. Are there any questions in the room or any comments, reflections? I have a question for you, Marney.
Uh-oh.
Now, I'm just curious what in your experience with regards to advanced care planning or advanced medical directives, when would you introduce that with regards to, considering the PPS? Or anyone else can answer that question?
I think there might be better people in this room to answer that. I have a bit of a personal tug-of-war, hate relationship with advanced care planning. So my very counselor response is, whenever the patient and family are interested in that, is when I would introduce it. I think it's the kind of conversation that we could all have in our well moments, and then revise along the way. I mean, one of the things we know is what we think about being intolerable or great or okay when we're well can be quite different as we go through an illness experience. So I think it would be great if we all had a look and a think about those kinds of things right now, with an understanding and expectation that we're going to revise them as we go along. I think the best time to talk about advanced care planning is couched in a conversation with people around what are their needs and concerns, and then bring out the paperwork.
Thanks, Marney. I didn't mean to put you on the spot.
No. Do you have an answer, though? You do more of this than I do, I think.
I'm just curious with regard to the PPS, so if that was ever taken into consideration in terms of the actual, from 100 to 0. But I love your answer, because it's at 100, right? Let's start talking about this in our lives and not wait till it's a moment that where we feel like we have to, know. Yeah, before 0. Yeah. There's another question online. What a fascinating talk. Thank you. How do these insights that you are sharing become central to our hospice palliative care practice?
Well, can I say, refer to Terry's morning talk? And part of why I spent so much time talking about where I come from is that I'm very aware as a psychosocial person that we're often one-offs on teams, and sometimes one-offs with very little authority or power. And so, I think how we make them central is a skill that we hone over years of work. So look for mentors, look for people who are really good at it, even if it's not about psychosocial stuff. Look around in your settings for people who are really good at getting their message across, and, passively or intentionally be mentored by them. Talk to them about how they get heard and how they have influence and how they got there. The other thing that I've realized, as I was listening to Terry's talk this morning, I think in some areas of my field, I'm an expert, but I'm not very expert at being a leader. And so I think recognizing that the knowledge and the experience and the perspective that you have is unique and so vitally important to patient and family care can sometimes be the leverage or the motivation or the inspiration that we need to actually speak up. And I think we get better and better at it the more that we do. I know for me, I feel more and more confidence stopping the bus and having a side conversation about something that I think is important, even though the rest of my team might not feel like that's the focus or the priority right now, because I know it to be important. And so I guess, I would just encourage people to remember the importance and uniqueness of our perspective as psychosocial people, or people who are interested in psychosocial, and to kind of keep bringing it forward and know that you get better at it the more that you do it.
Marney. One last comment here on, and any of you can jump in at any time. It's hard to see hands, but a comment that says, it is never too early to have the conversation. Also, serious illness conversation is a good framework for this. Are you familiar with the serious illness framework? So that's another framework that's used, developed in the US, but you could probably Google, and it's also another good framework to use. So there are frameworks out there, and if we need frameworks to guide our work, then yeah, they're there and they're available. Anybody have any questions, comments? You're all good, you're all hungry and ready to go. I'm just going to take then 1 minute of your time to graciously thank Marney for being with us today. I think she adds a wealth of knowledge and experience and leadership, because Marney did not mention, but she was part of the scope that was mentioned by Terry this morning, which is the social work competencies, and very much part of developing the training around those competencies. So very much a leader. And I really want to thank her for being here with us today and bringing your knowledge and your experience, and really helping us to frame our practice in a language that's used in our clinics, in our residences, and in our institutions, so that we can have common language and be able to kind of put forth what might be other issues that are present during those times for families and patients. So thanks very much. We will start back at 1. We hope that you'll all come back and join us for the rest of the day. We have 2 very exciting and interesting speakers this afternoon to complement our psychosocial all-day seminar. We have Maxine Ratner, who will be with us at 1, and Sharon Baxter and a couple of her colleagues later on this afternoon, and we'll all welcome Sharon back, and it'll be great to see her. So have lunch, and we'll see you at 1 o'clock, and thanks very much.